This episode was pre-recorded as part of a live continuing education webinar. On-demand CEUs are still available for this presentation through All CEUs. Register at allceus.com/counselor toolbox. I'd like to welcome everybody to today's presentation on supporting clients on medication-assisted therapies. I am Dr. Dawn-Elise Snipes. Today, we're going to define medication-assisted therapy because it's not just methadone anymore. We're going to explore barriers to treatment, identify benefits of medication-assisted therapy, explore the effects of opioids on depression, anxiety, pain, and PTSD, explore pain management with people on medication-assisted therapy, and identify the side effects of medication-assisted therapy and interventions to help people live their highest quality of life. What's our goal? As clinicians, what is our goal? We want to help people live a high quality of life, which means we need to help them reduce their symptoms of depression and anxiety, including agitation, sleep disruption, anhedonia, fatigue, and feelings of worthlessness and guilt. We want to keep them alive. That's a good thing. We want them to be relatively pain-free, remembering that as depression and anxiety go up, pain tends to go up, and as pain goes up, depression and anxiety go up. So there's a bidirectional relationship. Unfortunately, it's a positive bidirectional relationship. We want them to be as independent as possible. When people are struggling with clinical depression or significant pain and rheumatoid arthritis or something like that, they may lose a level of independence if they can't get that pain under control. We want to help them improve their interpersonal relationships, which we know tend to be disrupted significantly by addictive behaviors as well as chronic pain. We want them to be financially secure. They need to be able to hold down a job. And when people are in chronic pain, it's harder for them to be in attendance as much, and their productivity tends to go down. And when people are addicted to something that is, not controlled, when they're addicted to something like heroin or fentanyl, they're likely not showing up at work or being as productive as they really need to be. So we want them to be able to get to work and hold jobs. There are tens of thousands of people on medication-assisted therapy that hold gainful full-time employment, and you would never know that they were on those medications. There are others, whose dosing may not be right, or they may be supplementing their dosing that you can kind of get an idea. But a lot of people, the goal of medication-assisted therapy is to reduce the impact of heroin and fentanyl and help people find a way to reduce their cravings so they can move towards pure recovery, if you want to use that word. I don't like that word either. And we want them to be productive members of society to their ability. What does that mean? We want them to be able to purchase things and, pay their bills and participate in neighborhood activities and be good parents and do all this other stuff. And if they are in chronic pain, if they are clinically depressed, or if they are addicted, then that is probably going to negatively impact their level of, quote, productivity. So let's take a look more at this. Clients must first, in order to achieve these goals, enter treatment. They have to stay in treatment long enough to get through any post-acute withdrawal syndromes caused by switching to medication-assisted therapy. Methadone, Suboxone, buprenorphine, those are not exactly the same thing, if you will, as heroin or fentanyl, and they're not getting the same dose in order to get the high feeling. Therefore, you also may have certain post-acute withdrawal syndromes such as confusion and irritability and that sort of thing. Now, if you're working with a good clinic, the detox process or the switch over to medication-assisted therapy is relatively, and I use that term loosely, relatively painless, because the doctor will gradually step them down from where they are to a maintenance level dose. During this period, when we need people to stay in therapy, we need their neurotransmitters to balance out. We need their dopamine system to recover. We need their glutamate system to recover. Serotonin, need it to recover. Everything is kind of out of whack. So if we can help people ease this transition, then and not go back to using heroin or fentanyl or something illicit, then we're more likely going to be able to help them achieve sustained recovery. We need to get them to stay in treatment long enough to address biopsychosocial issues that trigger or maintain their illicit drug use. And I use the acronym SPACE. Social issues, their friends, who they're living with, the relationship issues that they may be having as a result of their addiction, physical issues, including hepatitis or HIV or reduced immunity, or the list goes on. Affective issues. We're going to learn that opioids are actually serotonin reuptake inhibitors, so they increase serotonin just like your SSRIs do, and they're also glutamate agonists, so they're increasing an excitatory neurotransmitter. This is interesting for us to know. And cognitive. When people are using, they are typically in less of a positive frame of mind, and they may have a more negative, externally locus of control attitude sort of thing. So we want to help them address their cognitive distortions and environmental issues. If they are living in a drug-infested area, if their roommates are using in front of them, if they are working on a crew where people are actively using drugs either on duty or after hours, all of those things may need to be addressed so they are not being regularly exposed to triggers. So think about this. And medication-assisted therapy gets a bad rap, partly because people don't understand exactly what it does. And yes, if it is misused, if it is diverted, used in extra doses, if it is combined with other drugs, yes, people can get high off of it or while they're on it. But using it as prescribed, they're not going to get a high from it. Likewise, do we have biases, or do you have biases toward clients who take antidepressants? My guess would be nobody in this chat room, nobody in this who's listening to this does. We work with people who are on antidepressants all the time. Not a big deal. We recognize that some people need the medication to help balance out their neurotransmitters to help them improve their mood or address compulsive behaviors. Do we have biases towards people who take benzodiazepines like Valium and Xanax and any of the others? It concerns me when I see that, but I also know people who that's worked very well for them because they have sporadic acute episodes of anxiety. So if it's being used as prescribed, I personally don't have a bias towards them. You have a bias towards clients who take opioids or gabapentin for chronic pain. I worked with veterans for a long time, and a lot of veterans take a lot of opioids because they have a lot of pain. And for some people, they've tried the other first-line interventions, and it hasn't worked to control the breakthrough pain enough. Some people need to be on some sort of pain control because they have some serious injury or illness that causes excruciating chronic pain. So do I have biases towards those clients? If they're taking it as prescribed and it's being monitored by a doctor, I personally don't have an issue with it. Would I love to see an alternative out there? Yes, I certainly would, but there isn't one right now. And yes, gabapentin is often used for neuropathic pain, and it is, it's not an opioid, but recognizing that we see people who have chronic pain that start taking medication that they may be on for the rest of their life because of a chronic condition. And as generally, I would think that most of us aren't going to hold that against them. If that's what the doctor's prescribing, we may not, we may see that there are some dangers to it, but when we weigh the benefits, we see that they might, actually balance out. So when we talk about antidepressants, methadone is a serotonin reuptake inhibitor. If somebody is self-medicating with opioids, and because opioids are a serotonin reuptake inhibitor, then they may be self-medicating. So when they switch over to methadone, part of what it's doing may be improving their mood. Can we replace that with other SSRIs? Probably. But that would require, in order to do it gently so they don't experience huge, awful detox effects, flu-like symptoms, it needs to be done gradually. And most of us have worked with clients, or let me rephrase that. It's rare, in my experience, to work with clients who try an antidepressant the first time and the dose and the antidepressant is the exact right one. So what we're doing with the methadone potentially is figuring out, okay, what is it that you need and how can we best help you do this, and letting the SSRI build up in the person's system, because we know it takes 4 to 6 weeks. Buprenorphine, as opposed to methadone, which is a full agonist, is a partial agonist. So no matter how much buprenorphine people take, it could be very problematic, but in terms of health-wise, but after they take a certain amount, if they take more, it's not going to get them any more euphoric, if you will. It has a ceiling level. It's going to get you this certain level of relaxation, but it's not going to get you high, and there's just no way around it. With gabapentin, we talked about that a few minutes ago. When we're thinking about physical dependence, and that's what we're talking about for a lot of people's concern about addiction, but physical dependence can develop with gabapentin, and people can experience withdrawal effects from gabapentin for up to 45 days. It's not a panacea either. There are no perfect solutions. What we need to look at is what is going to help this person have the highest quality of life possible. And methadone has a lot, and other medication-assisted therapies have a lot of drawbacks. And one of the things we're going to talk about towards the end of the presentation is how we can help clients learn to live with those side effects if this is the only way right now that they can figure out how to manage their pain and or their cravings. Oops. The review of terms real quick. An agonist is a medication that binds with the brain's receptors and produces opioid-like effects. Methadone, morphine, fentanyl, heroin. Those are all agonists, full agonists, so they can, go the full gamut, and people can get high off of them. Partial agonists have that ceiling. So it'll get you to a point of relaxation and contentment, but it's not going to get people high. Antagonists and are medications that block receptors and prohibit opioid-like effects. And this is your naloxone. This is the medication that we give to reverse an opioid overdose. Naloxone, interestingly, is also used in Vivitrol for alcohol cessation. Just being aware of that. These drugs are used for alcohol and opioids. Street and painkiller opioids, most of your agonists, are short acting. They get into your system and they get out in a couple of hours. Medication assisted therapy is long acting. The half-life is right around 15 hours, which is why people only have to dose once. However, the analgesic effects of methadone if somebody's taking it for pain relief, the analgesic effects are only about 4 or 5 hours. So the relaxation and the other effects tend to last, a full day once they take it once. Methadone does not create a pleasurable or euphoric feeling from mu receptor activation. It can help people feel calmer and more relaxed, but when it's used as prescribed, people are not going to get euphoric. The medications used in medication-assisted therapy to reduce cravings, prevent withdrawal, and help normalize brain function so that people can focus on developing the healthy thought and behavior patterns that will sustain recovery. Generally, if somebody is going to be maintained on methadone or any other medication-assisted therapy for longer than 2 years, the prescribing physician has to make a case, if you will, with the supervising authorities, the drug regulatory authorities, to support why this person needs to be on for more than 2 years. Generally, medication-assisted therapy is not supposed to go past 2 years, except for in cases where there is some unusual reason. Medication-assisted therapy provides individuals a taper of long-acting opioid medications as a way to wean them off of stronger opioids such as heroin. It's going to help them ease down and back off. Think about if you've ever tried to quit smoking. It's kind of like, taking away 1 cigarette a day, if you will, for, over the course of weeks. So it doesn't feel as much of a jolt to your system. It also gives the brain time to rebalance in a little bit more slower, gentler manner. A minimum of 12 months is required for methadone maintenance to be effective. This taper goes slowly, generally. If they do it quickly, the person experiences a lot of side effects, flu-like side effects mainly, and fatigue and rebound pain. So it's important that if a person wants to try medication-assisted therapy, they need to commit for at least a full year. Benefits of medication-assisted therapy: it reduces overdose risk. If somebody is getting the edge taken off, if you will, of their cravings, of their depression, of their anxiety, whatever it is that prompted them to use, then they're less likely to use something illicit that is less controlled. It improves the chance of survival, reduces the risk of relapse, improves retention and treatment for an adequate period of time to address those biopsychosocial issues we talked about. Reduce criminal activity associated with substance use disorders. If they're not having to steal in order to get money to buy whatever it is they wanted to buy on the street, which can be really expensive, then they're not going to have to engage in that criminal activity. Reduce negative health outcomes, including HIV and hepatitis, and improved birth outcomes among addicted pregnant women. Now, women will be maintained on methadone throughout their pregnancy. They've found that terminating methadone or opioid use suddenly while a woman is pregnant can cause miscarriage. So generally, when the woman is pregnant, she will be maintained on a level of methadone that is adequate to sustain her, and then it's up to the physician after she gives birth whether she continues to be maintained on it or not. Stigma is typically a social process characterized by let me answer this question. Will the baby need methadone? The baby goes through, unfortunately, methadone withdrawal. The baby's not, I know of no cases where the baby is ever given methadone, but yes, the baby will go through methadone withdrawal as soon as it's born. So stigma is a social process characterized by exclusion, rejection, blame, or devaluation that results from an adverse social judgment about a person or a group. The presence of stigma leads to ongoing discrimination and marginalization with a detrimental effect for clients, families, and communities, including decreased self-esteem, increased isolation and vulnerability, and a reduced likelihood for service access. Why am I talking about stigma? Because there is a huge stigma associated with medication-assisted therapy. There's a stigma in 12-step groups, or some 12-step groups. There's a stigma among many clinicians. There's a stigma among many doctors. So people who would benefit from medication-assisted therapy may not seek it out because of the associated stigma. Which brings us to associative stigma, is the process of being stigmatized due to having a close association with a person who is stigmatized. So people who are clinicians at methadone clinics may be stigmatized and looked down upon by clinicians who don't work there because they work in, quote, one of those clinics, as if the clinician or the significant other that's associated with the person using medication-assisted therapy is somehow tainted by the relationship. We need to get past this. If we want to help people find recovery once they've already gotten addicted to opioids, we need to figure out how to help them get off of them. Questions to ask when you're doing an assessment with a person: when do they start using opioids? What benefit are they getting from the opioids? The best way to figure out a good treatment plan for them is to figure out what the benefit is. Is it an antidepressant? Is it anti-anxiety? Do the opioids provide pain relief, and any combination of any of these things? Does it help improve their sleep, which when we have enough sleep and we're well rested, we tend to have less anxiety, depression, and pain? Does it increase their confidence level? I've had patients tell me that before. Or increase their energy levels. I had patients tell me that before. Now, if you know that methadone and opioids act on the glutamate receptors, which is our main excitatory neurochemical, then you might start going, that person may have insufficient glutamate for some reason, and the opioids are increasing it for them. We don't know exactly why, but we can understand that there is a neurochemical basis to it. Other questions we want to ask: does the person have access to health care? They need to be physically healthy. We need to help them get physically healthy in order to, live their highest quality of life. What is the state of the person's health right now? Are they in relatively good health? Do they have a lot of chronic pain? Do they have hepatitis? What's going on? What's the client's mental health history? And we want to look at mood as well as addictive disorders, because remember, opioids are often co-occurring with other substance addictions, and opioids have a high concurrence with in people who have depression, anxiety, or PTSD, because it is a glutamate and SSRI agonist. We want to know what the client's goals for therapy are, and what is their perception of treatment. What do you think is going to happen? Some clients think they're just going to come in, they're going to dose, and they're going to leave. That ain't the way it goes. Clients are required to participate in counseling of some sort. Now, some places run a little fast and loose with what they define as counseling for the clients. They're more interested in the number of people they can pump in and out, which really irritates me. But good counseling will help them address their biopsychosocial issues, and making participation in the program contingent upon getting their meds, contingent upon participating in counseling and staying clean, is one of the best ways to increase success rates. Now, when we talk about counseling, though, we also do need to look about barriers to treatment, barriers to them getting to counseling, and figure out how to help them work around that. We'll talk about that in a minute. We want to ask about prior treatment history. What's worked? What hasn't? And we want to talk about treatment not only for their opioid use, but also for depression, anxiety, any co-occurring issues they may have? Does the person have safe, stable housing? Think about Maslow's hierarchy. We need to make sure that they are getting their basic biological needs met. Do they have access to food, adequate income? What is contributing to this person's stress right now? Most people, when they come into a clinic, are not there and feeling just on top of the world. They have things that are contributing to stress, and we know that stress can lead to relapse. Who are the healthy social supports in the person's life, and what factors had an effect on this person's early life? We want to look at early childhood trauma, etc. What are actual and perceived barriers to treatment for this person? Cultural barriers. Some cultures are not okay with the use of methadone. And if the person happens to be in a 12-step program, there can be a lot of stigma associated with using methadone. Now, if you look back, oh gosh, it's on the infographic that I made. His name's escaping me right now. But one of the early proponents of methadone treatment was talking to Bill W., and the conversation basically went something like, Bill W. said, "I wish we could find an analog of methadone to help people with alcoholism when their cravings are so inescapable, in order to help them deal with those cravings so they can achieve sustained recovery." It was much more eloquent than that. But basically, Bill W. said, if this is going to help you get through this period where your cravings are just incredible and help you towards the process of recovery, then as long as it's prescribed by a doctor, yada, yada, good. Let's do what we need to do to help you be able to stay the course. So cultural barriers, it can be other cultures, it can be religious issues, whatever. Economic barriers to treatment. This can be no coverage from insurance. Now, dosing is typically not super expensive. It's, $8 to $15 per dose in general. But that adds up when you're doing it every single day, especially if you're making $8 an hour. Some insurance will cover methadone. Others will not. It's just important to look at economic issues. You also have people who work, and they work jobs where they get paid hourly, and if they have to be at the methadone clinic and miss the first 2 hours of work, then that's going to negatively impact them financially. And economically, we need to look at other issues like their ability to access transportation. Do they have a car? Can they afford gas? When I worked in Florida, the people who would come to the methadone clinic would sometimes drive in from an hour and a half away. That's a lot of gas for anybody to do, 3 hours round trip every single day. What are their finances like and insurance? What are their emotional barriers to treatment? Are there any? Do they have suspicion about the process? Are they anxious? Is there some contraindication mood-wise for them to be on methadone? What are their psychiatric issues and other addictions? This will have to go into a comprehensive treatment plan. For somebody to be able to be treatment compliant and stick with the program, we need to make sure we're addressing their biopsychosocial issues. Is there stigma associated with it? If their significant others are not on board, then they may feel like they've got to sneak around or it's not worth it. We may need to do some advocacy and education. Let's talk real quick about depression. Our endogenous opioid system, our natural-made opioids, are involved in controlling feelings of pain, stress, anxiety, hopelessness, and pleasure, and regulating levels of other neurotransmitters. When dopamine goes up, endogenous opioids typically go up. Dopamine is the go seek it chemical, and the opioids are the let's do that again chemical. Opioids interestingly, are a system depressant, even though they activate glutamate, and can increase depression in some people. In other people, the opioids may have the opposite effect. Treatment-resistant depression, major depressive disorder, impacts 10 to 20% of people with depression. So they've tried a gamut of SSRIs and tricyclics, and it's not working. Methadone and buprenorphine are serotonin reuptake inhibitors, like a lot of your SSRIs, and it also acts on the mu-opioid receptor and the glutamate receptor. Sometimes this is what people need to get them out of that trough. Ketamine is another drug that's not an opioid that also acts on the mu-opioid receptors and the glutamate receptors. And we've talked before about the fact that ketamine is now being used for acutely suicidal patients. Ketamine has a lower risk of respiratory depression and a lower affinity for mu-opioid receptors than the opioids do. So it's not mu-opioid receptors are the ones that allow people to have that euphoric feeling. Ketamine's not real crazy about them. It goes more towards the glutamate. Ketamine is the preferred treatment for a fast-acting antidepressant. They say it works between 20 minutes and an hour. People see substantial relief from their depression. Buprenorphine has shown great potential for use as an antidepressant. So for some people who traditional SSRIs and tricyclics don't work, buprenorphine may be an option because it activates, those mu-opioid receptors as well as the glutamate receptors. Some people are not crazy about going there. Heightened clinician awareness of the possibility of serotonin toxicity or serotonin syndrome is vital among patients taking opioids and other serotogenic medications. If they're taking opioids, even stuff from the dentist, and they're taking antidepressants, those medications work together synergistically and can increase serotonin too high, causing life-threatening serotonin syndrome. So the doctor really needs to monitor levels really carefully. Anxiety. Deficiencies in the opioid system can also contribute to anxiety and reduced serotonin. Opioid receptors and opioids themselves also play a role in stress and anxiety. The endogenous opioid system, the natural opioid system, boosts the effects of the benzos. So you're going, okay, so if people take benzodiazepines, if they take anti-anxiety medications, then our natural opioids increase their effectiveness. So if they take anti-anxiety medications and they take, prescribed opioids, they may also work synergistically. Now, the problem here is they work synergistically too well. It is life-threatening to combine opioids and benzodiazepines. It's, really, really bad mojo. Some parts of this opioid system can actually increase anxiety. And anxiety is also one of the symptoms of opioid withdrawal. Now, if you remember, you're like, well, does it increase or decrease it? It depends on the person. Serotonin's the same way. High levels of serotonin can actually increase anxiety, and low levels of serotonin can increase depression. So too much of a good thing can be a bad thing. Buprenorphine augmentation has also been effective in improving symptoms of obsessive-compulsive disorder compared to placebo. Just figured I'd throw that in there because you may see it being used a little bit more. Long-term use of opioids, including methadone, either illicitly or for therapeutic purposes, has profound effects on the perception of pain. Pain tolerance goes down because we are supercharging our opioid system and numbing things out. So then when that wears off, what would be a normal pain to us prior to using the opioids is now excruciating. We're so much more sensitive. It's important that people understand that as they're coming off of opioids, as they're tapering, they may experience greater pain sensitivity for a period of time. Gabapentinoids, tricyclic antidepressants, and serotonin norepinephrine reuptake inhibitors are the first-line agents for treating neuropathic pain. Gabapentinoids are used for neuropathic pain. We know this. And then you've got these two different categories of antidepressants. You're not seeing an opioid in the bunch. This is our first-line agent for treating neuropathic pain. Tramadol and other opioids are recommended as second-line agents. Interestingly, the new guidelines are showing that cannabinoids are newly recommended as third-line agents. They come ahead of methadone and Botox as fourth-line agents. Methadone blocks the euphorogenic effects of short-acting opioids. This blockade can be overcome when higher than normal doses of short-acting agonists are used, or there's increases in methadone dosing. So people can get high on it if they are taking methadone, but then they also use a bunch of oxy or something. Methadone is relatively ineffective with neuropathic pain. So there are only certain types of pain methadone's even going to be helpful with, which is another reason it's a fourth-line agent. Clients receiving methadone maintenance therapy often require higher and more frequent doses of opioid analgesics to achieve pain control due to cross-tolerance to different medications within the opioid class. They become tolerant to, opioids in the methadone class, if you will. So then if they start taking a short-acting painkiller like OxyContin, then they may need more of it because their body's already used to having the opioid in there. Obviously, we don't prescribe, so this is not super relevant, but we do want to be aware of the fact that there are very tricky issues in dealing with chronic pain or even acute pain when somebody's on methadone and then they have to go for oral surgery or they get into a car accident. Dealing with their pain is going to be much different than dealing with somebody who's not taking methadone, and it's important for them to alert their physician about the fact that they're on methadone so they can get adequate pain control. Up to half of patients with PTSD and up to 95% of people suffering from traumatic brain injuries develop chronic pain. PTSD is strongly associated with opioid use and abuse. PTSD and traumatic brain injury often co-occur and have amplify overlapping symptoms. When people use opioids, you're thinking, well, why would people use opioids? Well, they may start using opioids because of PTSD. Whatever happened was physically traumatic and they had pain, or they developed psychosomatic pain. I don't know. However, the use of the opioids provides temporary relief from PTSD symptoms, including arousal and the depression and apathy by increasing serotonin and dopamine. And it may decrease agitation and that sense of hypervigilance by decreasing respiration by binding with opioid receptors in the brainstem. It slows everything down so they don't feel as anxious. Interestingly, though, in 2012 was the height of the VA's prescribing of opioid painkillers, and it also was the time when there was the highest rate of veteran suicide. So obviously, the opioids may have been masking something, but we do want to be careful about people who are on medication-assisted therapy and suicidality. Supporting patients on medication-assisted therapy. Federal law requires patients who receive treatment in an opiate treatment from an opiate treatment provider receive medical, counseling, vocational, educational, and other assessment and treatment services in addition to prescribed medication. I've seen some really wonderful programs for this. The one in Gainesville is awesome. I've also seen some others, typically in your dispensing clinics for things like for Suboxone, where there's not as much emphasis on counseling. The 6-month retention rates for opioid therapy, medication-assisted therapy, seldom exceed 50%, and there are poor outcomes following dropout. So we need to explore innovative strategies for enhancing retention in buprenorphine treatment. Access difficulty. If they have to show up at 5:30 in the morning to dose, that might be too difficult. Or if they have to be at work at 7 o'clock and the dosing is not the right time. If they have unsupportive living environments, if we are not doing a good assessment and paying attention to co-occurring disorders, if there's expense that they have to shoulder for repeated doctor visits or dosing with no insurance, and just the time required for clinic visits. I remember at the clinic opened at 5 o'clock in the morning, and people would start getting there at 4:15 to line up for dosing, and it would be a long process. Risks for medication-assisted therapy toxicity. If they have recent or ongoing use of benzodiazepines, I said earlier, I'll say it again, that is life-threatening. That is really bad mojo. We want to make sure that the benzos are out of their system. If they're using other sedating drugs, including things that are mildly sedating and mildly sedating herbs like valerian or melatonin, or I can't think of others right now, but it's important if they're using anything else that's sedating, it could increase toxicity. If they have a lower opioid tolerance, I'm a lightweight. The doctor will prescribe, 2 pills every 4 to 6 hours. If I take half of 1 pill every 6 hours, I'm all but drooling on myself. I'm just like, okay, that's plenty. If the person has alcohol abuse or dependency, that increases their risk of toxicity. They don't feel as drunk when they're drinking alcohol when they're on methadone, so they can tend to drink too much, and then it also affects methadone levels. If they are greater than 60 years old, the liver does not clear medication-assisted therapy products out as efficiently. If they have severe or unstable liver disease, regardless of age, then again, their liver's not able to clear that stuff out as effectively. Respiratory illnesses such as COPD and asthma can increase the risk of bad side effects, if you will, for medication-assisted therapy, because a lot of these opioid medications tend to suppress respiration a little bit. So if people are already having problems breathing and oxygenating, that can be bad. Any drugs that inhibit methadone metabolism can be a problem. Eating grapefruit or drinking grapefruit juice, and even using essential oil of grapefruit, has been shown to potentially increase methadone levels. If somebody misses a dose, they can have a decrease in tolerance, because your tolerance to opioids goes down really quickly once you quit taking them. Or if they're in early stabilization where we're not sure exactly how much the person needs, then if the doctor goes a little too high, then there's a higher risk for toxicity. Factors impacting medication. Opioid use, how much they've been using, how long they've been using, gives us an idea about, or gives the doctor an idea about where to start. The route of opioid use, if they're using it orally, they're getting less of it in their system than if they're using it intravenously. If they are a polysubstance abuser, then that will impact how much methadone they need to be prescribed. The age of the client, as we talked about a minute ago, other pathologies such as liver or kidney disease, both of those filter out waste, genetic factors, and interestingly, pregnancy. When people are pregnant, they metabolize methadone as much as twice as fast. So a lot of times people who are pregnant need to dose twice a day in order to maintain their levels without starting to experience withdrawal. In response to your question about how did grapefruit juice or grapefruit produces that effect, it causes the body to not metabolize the methadone as quickly. It slows down the metabolization. Therefore, the levels stay higher. So when they go take their next dose, then they're actually, getting more than they should. Side effects of medication-assisted therapy, mood changes, and these can be different. We want to watch somebody who starts any sort of MAT. Immediately after switching to MAT, they're going from some uncontrolled dose to a controlled dose, but it's going to be less than what they were getting on the street. Therefore, they're not only are they going to experience some withdrawal side effects, they're going to feel a little bit hinky, but they also may have mood changes because of the altered stimulation of their glutamate and their serotonin system. 3 to 6 months after starting MAT, theoretically, they're on a relatively stable dose at that point, and they are addressing biopsychosocial issues, but that may trigger mood changes that are completely unrelated to their medication level. And then 6 months after starting medication-assisted therapy, people can also start having more mood changes. So we do want to watch in each of these 3 phases, knowing that there are different triggers for mood changes in each. When you get towards the end of treatment, people start developing high levels of anxiety about whether they're going to be able to stay clean if they're not dosing every day. Other side effects, headache. They need to talk to their doctor if the headaches are bothersome. There's not much as clinicians we can really suggest for that. Dizziness and blurred vision due to alterations in neurotransmitters. Definitely a problem. We want to make sure that they're not driving until they know how the medication affects them. We want to assess any impairments caused by dizziness, such as, like I said, driving, their ability to walk stairs, their ability to exercise, and carrying an infant. If you think about walking around with a baby in your hands, if you suddenly get dizzy and fall out, the infant's at risk. So we need to help, caregivers figure out, if you're on methadone, how can you best, make sure that baby is safe. I'm not saying not to be on methadone if you've got an infant. I'm saying you need to be cognizant of the fact that you're going to potentially be a little unsteady. Have clients monitor their blood pressure and heart rate. If their blood pressure goes too low, then they become hypotensive, they also may faint or get really dizzy. And their heart rate, if it goes too low, then they may not be oxygenating enough, which will contribute to dizziness and blurred vision. And all of that data needs to be reported to the attending physician. Drowsiness can happen due to alterations in neurotransmitters. Serotonin is used to make melatonin, helps us get to sleep, yada yada. Opioids also reduce cortisol levels. So cortisol is our fight or flight chemical, and it's the one that helps us get out of bed in the morning because we're raring to go, and then it decreases throughout the day. When it's at its lowest, we go to sleep. Well, opioids reduce cortisol levels, so people may have a premature dip in their cortisol, which can lead to feelings of sleepiness. Sleep changes and can also contribute to drowsiness. We want to assess sleep quality and quantity. And inadequate respiration. When people are taking opioids, they tend to be more sedated, so a lot of times they're not breathing deeply. Most of us don't breathe deeply very often, which is why we yawn. If people are starting to feel sleepy, or preferably even before it, they should try deep breathing throughout the day to make sure they're staying oxygenated. Sexual impotence and decreased libido affects 30 to 40% of people on medication-assisted therapy. See, I said it wasn't a perfect solution. And this is due to lowered sex hormones, especially testosterone. Clients may have difficulty in their relationships because of this, with their self-esteem because of this, and even remaining treatment compliant because of this. We need to address it. We know that when people are on antidepressants and they have this problem, that they have difficulty maintaining compliance. It's really not any different here. Naltrexone, remember, that's your agonist that is used for alcohol, and it's also when somebody gets the buprenorphine naltrexone combination, which is trade named Suboxone. Naltrexone can produce anhedonia and reduced libido, decreased lubrication, and anorgasmia in women. If for women who are having sexual side effects from medication-assisted therapy, they may need to consider changing their birth control regimen. And for men, they may need to consider seeing their doctor. Both of them may benefit from some sort of hormone replacement therapy. Osteoporosis is a common side effect due to endocrinopathy, and I'm not going to go into the big details of that right now. We do need to educate our patients that if they're on methadone for a long time, that osteoporosis is potentially a problem. They need to engage in weight-bearing activities, make sure they're, getting a good quality diet, and talk to their doctor about other preventative measures. Dry mouth and constipation. I'm going to put them both together because when we get dehydrated, we also get constipated. But because opioids slow down the system, people may get constipated. Have them carry a water bottle with them. That will help remind them to drink, so they're drinking more often throughout the day. Encourage them to exercise. Exercise not only stimulates our desire to drink, especially if we've got a water bottle right there, but it also gets our system going, and it can help move things along, if you will. If they've got dry mouth, they can also use a dry mouth rinse. They sell them at big box stores that you can go to. Sleep disruption. We want to look at sleep hygiene. Some people have a lot of difficulty at first sleeping on a normal schedule. Whatever their issues are, we want to help them look at that, because remember, we are monkeying with the serotonin system. Difficulty concentrating. It can be hard. If you've taken opioids before, it can be, how hard it can be to kind of compose your thoughts sometimes, especially if you're, on medication-assisted therapy, so you're not getting the euphoria, you're not feeling horrible, but you're also dealing with all the stuff they've got to deal with in recovery. You can imagine that all the stress and everything that's going on with them, it's going to be hard to concentrate. Encourage them to take notes and plan ahead. At this point in time, they are in a sort of mini crisis sort of situation, and we want to help them recognize that it takes a lot of energy to recover. And as their brain rebalances, different things are going to happen. Some days are going to be better than others. Just take notes, plan ahead. Reduce distractions when you need to focus. Encourage them to take frequent breaks. Sometimes chunking things in 15 or 20-minute segments is easier. Encourage them to practice good time management and to stay organized. Now, they may need help from a counselor figuring out how to take all this stuff and dump all of their responsibilities for life into this mix and come up with a schedule. But, that's certainly something we can do. Less common side effects of medication-assisted therapy include suicidal ideation, hallucinations, paranoia, and delusions. Just be on the lookout for those. Other issues that clients may face include family judgment. We talked about that some earlier. A lot of families perceive medication-assisted therapy as swapping one drug for another. Well, it kind of is and it kind of isn't. Yes, you're swapping one thing that you ingest with another thing that you ingest. One gives you a sense of euphoria and a high, and it's uncontrolled, and you could die from it. The other is controlled. You can't get the euphoric experience from it, and it's helping you get through to the point that you've sustained recovery. And the best analogy that I can give most people who have issues with it is, after you've had a surgery, for example, when do you want to leave the hospital right after you had the surgery with no medication and just grit through the whole recovery process? No, that would be unbearable and inhumane. Medication-assisted therapy is sort of a similar way for mental health issues. The medication-assisted therapy is what is used to help the person deal with the pain through the recovery process until they don't need it anymore. At work, people can experience judgment. There are some occupations that you cannot take methadone, and those would be your safety-sensitive occupations. There's just no way around it, and they have a special carve-out in the ADA and stuff. But the Americans with Disabilities Act and many state protections do protect workers who are taking a legal medication as prescribed by their doctor for a verifiable condition. Asking an employee or a prospective employee about legal drug use and or prescription medications is prohibited unless those special conditions are met. It's one of those occupations where you cannot use any sort of medications. And employers may only ask about and or test for prescription medications when such inquiry is job-related and consistent with business necessity, not just because they want to. Methadone has higher treatment retention rates than buprenorphine naloxone does, and that's the trade name Suboxone, while buprenorphine naloxone has a lower risk of overdose. For all patient groups, physicians should recommend methadone or buprenorphine naloxone treatment over abstinence-based treatment, according to the guidelines. Now, I have worked with a lot of people and talked to a lot of people over the course of many, many years, and some people say that the detox from the medication-assisted therapy is worse than the detox from the heroin or the fentanyl. And part of that, my suspicion, is because the medication-assisted therapy, like I said, is a longer-acting medication. Therefore, where the opioids, street opioids, would get out of their system in a couple of hours and then they'd be recovering, the longer-acting opioids take longer to get out of their brain and out of their system and take longer to reset. Therefore, and I've seen people wean off of it without much problem because the doctor does it very, very slowly and gently. But there are not a lot of doctors that are willing to do it that slowly and gently. A lot of times, the stuff that, when I hear that from clients, it's clients who have dropped out of treatment or been kicked out of treatment because of noncompliance, and they didn't get the slower, gentler detox. And yeah, that can certainly be excruciating. Let's see. As far as the use of CBD oil, I didn't find anything in the research that indicated any level of clinical effectiveness with this particular population. However, it doesn't mean it doesn't exist. It means it hasn't been studied, because yes, there's a lot of research out there that indicates that CBD oil can help with like arthritic pain and joint pain and those sorts of things. So it may be a good adjunct to take the edge off. However, CBD oil does affect the neurotransmitter systems. So just like if somebody was taking an antidepressant, they would need to be closely monitored to make sure they didn't develop serotonin syndrome. That would be my biggest fear about somebody using CBD oil concurrently with methadone or buprenorphine naloxone. Are there any other questions? And like I said, there are a lot of clinics that do it right, and they've got really awesome, like 6-month IOP counseling programs, and they address the biopsychosocial issues and yada, yada, yada. And there are a lot of them that don't. You tend to see more counseling in true methadone clinics as opposed to in places where doctors have gotten a permit to dispense the buprenorphine naloxone combination. So I'd much rather see my person going to a OTP clinic. All righty. Just for an aside, if you work with clients with dementia, I may do it today, maybe tomorrow, recording a episode of the Case Management Toolbox podcast on case management for clients with dementia. And I learned a whole lot of new stuff doing that because I don't typically work with that population. And then on Thursday, to kind of piggyback onto that, we're going to be talking about communicating with people with cognitive disabilities. If you want to find out which ones are the good clinics in your area, there are not many. I can tell you in most places, especially full-blown methadone clinics, go visit the clinic, ask for a tour. Most clinics are more than happy to give you a tour and let you see what they do and their facilities and their curriculum and all that kind of stuff. If they're not, that would give me pause, if they're not willing to let another professional come tour. Yes, in the case management podcast, I do address the difference between dementia and the normal aging process, because sometimes people start normal aging and their loved ones freak out that they may be developing dementia because the person gets a little forgetful or is slower in finding their words, which I've noticed over the years. I've gotten a little bit slower too. Oh, neat. Ashley says that where she is, they have a new ketamine clinic. So I'll be interested to see some of the research from that. Um, hmm. That's unfortunate that they're making the ketamine very expensive, because I know it's not. My vet uses it when he's got to come out and do major procedures on the donkeys, and because it's basically a horse tranquilizer, and it ain't that expensive. So that's unfortunate. It's probably the fact that it has to be in those special nasal preparations or whatever. But remember, though, you can potentially go to the pharmaceutical company's website and go to the patient assistant program area and get waivers if the person is going to be on ketamine therapy for any period of time. And they may be able to get patient assistance from the pharmaceutical company. The doctor just has to sign a little form and fax it in. I'm not saying that that will necessarily happen, but it can't hurt to try if you've got a client who is not covered under insurance, and they would definitely benefit from it, to create that, quote, window of treatment. Between writing notes, filing insurance claims, and scheduling with clients, it can be hard to stay organized. That's why I recommend Therapy Notes. Their easy-to-use platform lets you manage your practice securely and efficiently. Visit therapynotes.com to get 2 free months of Therapy Notes by just using the promo code CEU when you sign up for a free trial at therapynotes.com. If this podcast helps you help your clients or yourself, please support us by purchasing your CEUs at allceus.com or getting your agency to sponsor an episode. A direct link to the on-demand CEUs for this podcast is at allceus.com/podcast CEUs. That's allceus.com/podcast CEUs. To sponsor an episode of Counselor Toolbox and reach over 50,000 clinicians per week, go to allceus.com/sponsor. Thank you.